right, so this class I'm going to be talking about our venous duplex reports. There are basically three main type of venous duplex exams that we do. So venous duplex exams. The first one is to rule out Dvt/phlebitis. The second one that we do is our venous reflux. The third one is going to be our vein mapping. So in terms of the venous duplex exams we do, by far and away, the most common is going to be our rule out DVT or phlebitis. So our indications, for doing a venous duplex exam to rule out DVT, there's a good number of indications, all of which, would be acceptable. Of course, we're going to have shortness of breath, pain, swelling. It's going to be our obvious ones, as well as discoloration, particularly redness. Other indications, potentially be tachycardia, chest pain. When I say pain, we say pain in extremity. Going for indications, remember back, there were certain types of cancers that make you more susceptible to developing DVTs. Particularly like pancreatic cancer, your GI cancers, like stomach, esophageal, lung cancer, even breast cancer. More indications, it could be post-operative, so patients that are post-surgery could potentially be susceptible to developing blood clots. Patients who are bedbound. Other indications could be patients who have history, long travel, where they're sitting or standing for long periods of time. History of DVT. Patients who have had DVTs in the past are more susceptible to developing clots in the future. History of PE. History of CVA, stroke, with a PFO. You have a stroke patient and they have a known PFO, they'll oftentimes order a leg Doppler to rule out a DVT as a potential source of embolus for that stroke. Patients who've had any sort of trauma. So that could be trauma to the extremity or the limb, or trauma to vessel. Trauma to the vessel can include, repeated bloods drawn, IV catheters, line placements.
Pregnancy.
I'm sorry?
Pregnancy.
Yeah. Pregnancy in and of itself isn't necessarily an indication, but if she's pregnant with any of these other symptoms, for sure,
Cool.
then yeah, for sure. Pregnancy is a risk factor. Yes, it can be, definitely, but it's not like you're not just gonna be like, oh, I'm pregnant, I gotta do a DVT.
Got a DVT now.
So again, just make sure, you know, but when you get your rec, that you have a proper indication, and know that rule out DVT is not an indication. So if you get a script and order that comes in that says just rule out DVT, you have to call the doctor, call the ordering physician or PA, whoever ordered the exam, be like, why? Like, why are we ruling out DVT? Because if you do that test and it's just a rule out DVT, the hospital may not get paid for it, or your doctor's office may not get paid for that exam that you do. And then they'll come back and get angry at you. So when submitting to the insurance companies, you need a proper indication. So, and oftentimes you can find it in the patient's chart, you know, like, you know, there'll be some mention of a nurse note somewhere like, oh, their limb was swollen, or, you know, you can look up their vitals and tell if they're tachycardic or if their O2 stats are low, you know. So short of breath, you know, they would have low oxygen saturations. Or they maybe have a history of cancer, you know, so. You can do a little digging on your own if you can't get in touch with the doctor on the floor. Oftentimes doctors are even hard to get a hold of, so nurse is usually a good first call up to the floor, be like, hey, you know, does the patient have any symptoms? You know, they'll usually give you the information you need. So indications for a venous reflux exam. You have a couple of the same similar indications as your DVT study. So for venous reflux exam, if patients having pain in the extremity, swelling, particularly chronic swelling. So those are the patients, you know, like my legs swell up during the day, I put them up at night, the rest, they go down, and then next day they swell back over again, swell up again, you know. So it's an ongoing thing. So this could be skin changes. So under skin changes, you know, we could have venous stasis ulcers. Stasis ulcers. Slash discoloration. So discoloration would be that, you know, brown pigmentation in that gator zone. Gator zone is in just above the medial malleolus. Venous stasis ulcers. Obvious would be presence of varicose veins. And also come under your history of DVT / phlebitis. So again, as we know that DVT or phlebitis can damage the valves, which in turn can lead to our venous reflux. And our indications for our vein mapping. So indications for vein mapping, these are going to be any patients that are in need of dialysis. So patients with kidney disease. We need dialysis. Other indication could be history, coronary artery disease. Need of cabbage. So cabbage is our coronary artery bypass graft. So they could potentially, we'd be doing a vein mapping to assess the vessels for use for bypass for the coronary arteries. Then you can also have history of peripheral arterial disease. History of PAD, peripheral arterial disease. So we could do a vein mapping to assess the veins for use and potential for bypass for arterial occlusion in the extremities. That's your PAD. Need extremity arterial bypass. Those are three main duplex exams, that we're going to encounter, that you're most likely to encounter. So this class, I'm really going to focus on that first one, because that's by far and away the most common. And how do we, formulate these reports for our DVT studies? I mean, yes, we are, trying to determine, is it positive or negative for DVT or phlebitis? But there are also some additional components to your report that you have to be able to look at a waveform and kind of interpret, the waveform, venous waveforms, and understand what that could potentially mean and what could potentially be going on in that patient. So there's some descriptors that we use for describing venous waveforms. So the first descriptor that we have to figure out with the venous waveform, is going to be our flow direction. Flow direction. So that's going to be antegrade, retrograde. The next descriptor that we use is called flow pattern. So flow pattern can be broken down into a couple different terms that we use. The first one being phasic or phasicity. So phasicity, that refers to our respiratory variation. So first, respiratory variation. So when we're describing phasicity, do we have respiratory variation? Is there reduced phasicity, decreased phasicity, or even absent phasicity? So absent phasicity. It's called continuous flow. That's when we lose those nice rolling hills with our breathing. We just have continuous forward flow. So I have some pictures actually I uploaded to D12 that shows all these. Another descriptor for flow pattern that we could use is pulsatility. So, all right. Pulsatility, yes. So is that waveform pulsatile? So pulsatility is determined by function of heart. Function of heart determines pulsatility. Veins or venous flow. So when I say function of heart, we're primarily talking the right side of the heart. So right atria, right ventricle. Things that could add to pulsatility or create pulsatility within the venous waveforms, you know, would be AFib, atrial fibrillation, congestive heart failure, right-sided heart failure, pulmonary hypertension, tricuspid regurg. So basically, when we're looking at the venous waveform, we're looking to see, is it phasic or is it pulsatile? If there's absence of phasicity, we refer to that as continuous flow. We can also potentially see regurgitant flow. So that would be, you know, flow above the baseline. Regurgitant. So we get momentary flow above that baseline. So in addition to flow pattern, when we're doing our lower extremity venous duplex to rule out DVT, you also have to determine if the vessel demonstrates augmentation. So we're gonna look for augmentation. So is augmentation, is it normal? Is it decreased or reduced? Or is it absent? So augmentation will help in determining possibility distal thrombus. So if we have absent augmentation, you know, it'd be pretty safe to assume that we have a distal thrombus that's occluding that venous blood flow from getting up to where we're imaging. So absent augmentation would potentially mean that there's an occlusive thrombus completely blocking that vessel. If we have decreased or reduced augmentation, potentially it could be a partially occlusive DVT that the patient has. So we're also going to look and assess for reflux. Look for reflux. We're also going to also keep our eyes open to look for the potential for fistula flow. Fistula flow. So patient may have had a catheterization or procedure done. Say they went to the cath lab, they went into the artery, they stuck too far, hit the vein as well, and created a fistula. One of the things we're going to look for, particularly in the vessels higher up in the groin, in the common femoral, is the presence of fistula flow. And fistula flow is very unique. So anytime you see very high velocities, if you're in the common femoral, so turbulent, high velocity flow, and proximal vessels. So if you're in the legs, that would be, your common femoral or external iliac. If you're in the arms, your more central vessels like your medial subclavian or innominate. Because we know that even if the fistula is lower down in the leg, that blood flow is going back up. So we'll exhibit signs of that turbulent flow higher up. So don't be looking for, like, if you suspect a fistula, say lower down mid thigh, below the level of the fistula, your waveforms won't look, that different because you're below that level of the fistula connection. So you may have some increased flow, but you're not going to have that markedly increased arterialized, turbulent flow that you would see in fistula. But the vessels higher up above that puncture site or that fistula connection will now be arterialized and demonstrate fistula flow. All right, so these are some charts that I uploaded to D2L. Again, flow direction. I like to keep my veins below the baseline. So know what your normal flow direction. So, antegrade versus retrograde versus absent. So then this is an example, of our phasic waveform. So this is nice respiratory variation. So that's why it's important for you to really optimize your waveform. So for phasicity, optimize your waveform. Optimizing your waveform, you're going to decrease scale to make waveform larger. Baseline. If I have my venous flow below the baseline, I'm going to bring up my baseline so it's near the top of my screen, or when I'm sampling. See if you can see in this picture, they brought up their baseline. They decreased their scale so it's sufficient so we can see a nice large waveform and really appreciate, the respiratory variations. So if this was, if our scale was high, we may not really appreciate much of a respiratory variation, and we might run the risk of calling it, continuous flow. And by calling it continuous flow, that could potentially indicate a thrombus that's higher up that we're not seeing. So a more central or proximal thrombus. Because remember, this phasicity, this respiratory variation is a result of the lungs. influence from the lungs and our breathing. So this would be, an example of decreased phasicity, potentially, if we were comparing, if this, say, was on the same level, but the opposite leg. Then another flow pattern that we have is pulsatility. So again, this is an example of a very pulsatile waveform. So it almost looks like an arterial waveform, it's very pulsatile, but this is a result of cardiac function. So anytime you see a pulsatile waveform, those are patients that have congestive heart failure, particularly, right-sided heart failure, AFib, pulmonary hypertension, pulmonary edema. Again, so this is an example here of, what continuous flow would look like. So this is a steady, consistent Doppler signal with minimal to no variation in flow. So again, if we're doing a lower extremity duplex, so I would even make this, I would optimize this even more, lower my scale even more and try and make this to really try and pick up if there is any, minor variation. Then we could also potentially have regurgitant flow. So this is, flow that goes above the baseline for a period of time. So this is also typically seen with severe tricuspid regurgitation in patients with, potentially severe congestive heart failure. Sorry, I forgot to mention. So there is another descriptor I forgot to mention too. Sorry, spontaneity. So another descriptor that we use with our venous duplex reports is describing if the waveform, or I'm sorry, the venous flow, if it's spontaneous or not. So spontaneous flow is flow that occurs naturally without us having to do anything, without having us having to have the patient augment or Valsalva. So this is forward. Curves. Out. Having to augment, salva, so again, you can see, particularly in the pro or proximal vessels, you should have spontaneous flow. So this is a patient, that demonstrated non-spontaneous flow. We only were able to observe flow when they augmented. So with spontaneity, it's also important to remember there is decreased or even loss of spontaneity or spontaneous flow as you move distal, or as you move distally. So the further away from the heart and lungs you get, the less spontaneous the flow becomes. So I know in my ultrasound lab, when we described spontaneous flow, it was pretty much relegated to common femoral and femoral vein. So they didn't, in our little worksheet box that we check out, they didn't really ask us about spontaneous flow in the like popliteal or calf veins. We had to mention augmentation at all segments. We had to mention phasicity at all segments. So try and get phasicity. You know, if I wanted to have them demonstrate phasicity, you know, in a segment distal that didn't have spontaneous flow, if I was doing legs, you know, I'd have them take a big deep breath out to see if that created flow. Conversely, if I was doing arms and I wasn't able to demonstrate, and I wanted to demonstrate phasicity, I would have them take a deep breath in for the arms. So this just shows augmentation, so Valsalva, calf augmentation. So a normal augmentation, potentially this one could be reduced, and then absent augmentation. It's an example of what reflux would look like. And then this last one is your fistula flow. So this is your arterialized venous flow that's very turbulent with high velocity. With a lot of spectral broadening. And these are some peripheral venous waveforms. So again, so peripheral veins, you know, in the extremities. So you could see your respiratory variation. So when you breathe out, you get increased flow. Breathing in and then exhaling again. With upper extremities, it's the opposite. So inhalation, you get increased flow. And exhalation, you get a decrease or even a cessation of flow. So this shows pulsatility. So remember when we were talking about our central veins, when we're doing the arms, are pulsatile. That's due to the atrial contraction and being in close proximity to the heart. So pulsatility can be normal in the upper extremities due to close proximity to the heart. This is proximal IVC. So when we get into our mesenteric Dopplers, you know, our hepatic veins should have a similar waveform to this, because again, those would be close to the heart as well. Let's see. So in addition to being able to look at the waveforms and describe them, you also have to be able to, if we do encounter DVT or clot, be able to determine the difference between acute versus chronic DVT acute thrombus versus chronic thrombus. So acute versus chronic thrombus. So our sonographic characteristics for acute thrombus. It's going to look anechoic / hypoechoic. Hypo, it's going to look dark. Chronic thrombus is going to look hyperechoic / echogenic. Acute thrombus will look homogeneous. Whereas chronic thrombus will look more heterogeneous. Thrombus typically have smooth borders. Smooth borders. Chronic thrombus, irregular. Regular borders. Acute thrombus can be poorly attached. Or free floating. So you might see this thing flopping around in the vessel. Whereas chronic thrombus is firmly attached or well attached. So in terms of the vessels, so with acute thrombus, we see increased vessel diameter. Chronic thrombus, you have small, contracted veins. So with acute thrombus, we may have small or absent collaterals. The chronic thrombus, we have large and or numerous collaterals. Acute thrombus, non-compressible. Chronic thrombus, it's going to be partially to almost completely compressible. So what else? Acute versus chronic. So with acute acute thrombus will have absent or partial let's say color flow or Doppler flow, absent or partial flow. So flow within the vessel can be completely absent, or we can have partial flow through that vessel. Chronic DVT, we have recanalization. Of vessel. With almost complete flow. So almost complete vessel flow or almost complete vessel filling. So when that vessel recanalizes, we may see, you know, that echogenic chronic DVT still within the vessel. When we put color on, we're pretty much getting the whole vessel filling with color. And may actually, you know, mask or even cover up, you know, that chronic DVT. So that's why our 2D picture, you know, is also important when we're assessing for DVT, you know. I'm missing anything? Anything we could think of? So acute DVT, we described more of like a spongy appearance. Chronic DVT is, you know, more rigid. Getting a couple pictures. All right. So we want to describe the thrombus as acute versus chronic. And then we also want to describe if there is a DVT present. So again, if thrombus is seen, we want to identify patient, which vessel is involved, extent. So how far up does this thrombus go? How proximal does it go? How far down does it go? Which vessels are involved when we're describing the extent? Identify location, extent. Again, we want to mention it's acute versus chronic. Then we also want to determine, is the thrombus occlusive versus partially occlusive. Those are going to be our main things that we need to include in our report. When we're writing a preliminary report, if we find a DVT or find a thrombus, so I want to describe the location, which vessel, the extent, how many vessels are involved, how far up does it extend, does it appear acute versus chronic, and is this thrombus occlusive or partially occlusive? So is there blood flow getting through that vessel, or is the vessel completely occluded? So this is a picture of, you guys can see this, right? So this is a common femoral vein with the greater saphenous GSV junction. So this would be your saphenofemoral junction. So this is with, without and with compression. And then your color Doppler box over that vessel. So what would this be? So would this be acute or chronic?
Acute.
Definitely acute, yes. So we have, anechoic to very slightly hypoechoic intraluminal echoes, and absent blood flow. The vein looks big, it's dilated. So yeah, that's 100% would be an acute thrombus. You see this one now? Did it change? I was having a little issues with this. So do you see one now, like with the Doppler flow?
I don't.
You don't? All right, let me stop sharing. Do it this way. Now, right? Now you see it?
Yes.
All right. I don't know why it does that. When I try and switch like pictures, it wasn't letting me. So what do you guys think about this one? What does this look like?
I'd still say acute.
Sure, definitely. That's a big dilated vein. So this looks like, again, this is our common femoral with our greater saphenous coming in. So now we're in long. Again, you could see this spongy-like thrombus within the vessel. So this is, again, so hypoechoic, a little anechoic over here, absent flow. So there's no blood flow getting through. So if I had to describe this, in my report, I'd say, if this was the only segment involved, there is most likely this would be non-compressible. So I'd say left common femoral vein is non-compressible and demonstrates hypoechoic intraluminal echoes with absent color Doppler and spectral waveforms, indicating acute occlusive thrombus within the left common femoral vein with extension into the proximal greater saphenous vein. It depends how far down this goes. This looks like a big clot. So this patient's probably clotted down the leg, I would imagine. So this would be that, extensive DVT. If you saw this patient probably has an extensive DVT all the way down the leg, but we don't know that just based off this picture if I had to describe it. So again, you want to describe, is it acute versus chronic? So this is definitely acute. You want to describe, the intraluminal echoes. Are they hypoechoic, anechoic intraluminal echoes, hypoechoic? Is it partially occlusive or occlusive? So this would definitely be occlusive. So way you say it's occlusive, without in your report, you say demonstrate or absent, color Doppler or spectral waveforms, indicating occlusive acute DVT in the left common femoral vein. couple other ones on here. What about this guy?
Chronic.
Chronic.
Chronic, yes, good. So in our transverse view, most chronic DVTs are going to look like a little band going across the vessel. They could potentially run across the middle of the vessel. They could be along one of the walls, the anterior wall, posterior wall. So that's a good transverse view of what chronic DVT. And when you compress, it almost compresses all the way down. So that's almost full compression. But when we go on long, we can really appreciate, that DVT. And these chronic DVTs can be quite long in length, actually. So they could be a large segment. This patient may have had a long, segment of DVT in the past. And when it healed, it left this chronic fibrotic strand within the vessel. This is the chronic DVT. So we could see some color flow getting through. I bet if I raise my color gain, I could fill this more with color. So in case of chronic DVT, you may have almost the complete vessel filling with color. So you may not even see that, that chronic strand running along the middle of the vessel there. Yeah, so this is, linear, echogenic, it's irregular.
Dan, with chronic DVT, would you more likely see varicose vein, or is that just more associated with reflux?
That chronic DVT could potentially be running through the vessel and preventing. Let me just screen share. So you see me. So if I have a chronic DVT, and I'm in my vein, so like I have my my vessel, my valve, and my vein. So if that chronic DVT is running down that vessel, it can prevent those vein valve flaps from coapting properly and cause the reflux. So for sure, yeah, chronic DVT definitely will lead to reflux. Depending on the location of it, if it's affecting that those valves. So in addition to like when you have DVT that develops, it'll form on those valves as well, form around the annulus, and can damage the valves and the annulus as well. So it's not only that maybe strand of chronic DVT that's running through it, the DVT itself will oftentimes damage those valves and create the reflux as well. So in a way, it makes the valves more fibrotic, so they're stiffer, less compliant. This is another example. This is a chronic DVT as well. So this one is located along the posterior wall here. And again, we have almost complete compression of the vessel. And if we go in long, we can appreciate, this echogenic plaque along the, not plaque, echogenic thrombus along the posterior wall of the vessel. So it can even become calcified a little bit, and looks like we might be getting a little bit of shadowing there. So this is really fibrotic. So this stuff most likely isn't really going to go anywhere once it's gotten to this point. So this patient's going to live most of their lives like carrying this chronic DVT. Who wants to try this one?
I think it's chronic.
Chronic.
I was gonna say acute, so clearly I suck.
No, I'd say you're both right.
You're
all right. So this is kind of a trick one. So this is acute thrombus posed on chronic. So this patient has that chronic DVT that the arrow is pointing to, running down the middle of the vessel. But there is now acute thrombus that's developed along that chronic DVT. So that's why history of DVT is an indication for developing new thrombus, because that chronic DVT acts as a nice surface now for new clots to form along. So kind of think of it like an IV catheter, like running through a vein. It's similar to that. If you have this irregular surface, this rough irregular surface now in the middle of your vessel or along your vessel wall, that's a nice surface for new clots to form on. So this would be acute on chronic. So this is an acute DVT. So if you had to report it, there is acute DVT seen within the left popliteal vein. So if I put color on this, there'd probably be absent flow, it'd probably be non-compressible. But you can also mention, as per, maybe we have a patient history, as per patient history of previous DVT, there is a chronic component noted with echogenic linear intraluminal echoes. So yeah, so you're both technically right. That is chronic, but there is the acute component. So. Stop share. What about this one?
Chronic.
Looks like it, right?
I was gonna say chronic too, because it's like partially
Almost
compressible.
compressible.
What if I told you this wasn't a DVT at all?
Then I'm quitting.
You're quitting. So this is actually the valve. So this is the valve annulus. So they're compressing right where the valve annulus is, and this is the valve that you'd see, that valve that we have right at that GSV junction. So that's actually a valve. So again, just be careful, if you're going to call something chronic DVT, make absolutely sure you're not over a valve and that you're actually it's not compressible because of the valve annulus that's there and the valve. That's why I like when I'm doing my images, get away from those valves. Like if you want to take a picture where a valve is, be 100% sure that you can prove to that doctor that that's a valve and not a thrombus, not a chronic DVT. Because depending if you're new, they may question you. And you don't want them to question you. It's a valve. You saw it's a valve. So get away from that area. Take your picture somewhere else. Don't give them a picture like that.
So it's not going to compress all the way if you're on the valve?
No, yeah, you can get the valve annulus will oftentimes prevent it from being fully compressible like that. Yeah.
Mm-hmm. What if you can't see the valves, like on
Can't
the
see
patient in the vessel? Yeah.
I mean, it's a good question. So, I mean, you could try and if you're going to be able to see the valves, long is going to be your best shot at seeing the valves. So I would if you're questioning like an area that's not compressible like that, turn in long. You can really turn up your 2D gain.
Mm-hmm.
By doing that, you may be able to visualize the valves at that point.
Okay.
But if you're not 100% sure, then you could take images of it and leave it up to the doctor to decide, be like, I see this area may represent a valve, may not. So you can, mention that to the radiologist or the doctor in your report or, verbally mention to them. And then it's essentially up to them to decide if they want to call it a DVT or treat it as a DVT.
Okay.
I mean, that would look chronic. So this patient would have to have had, a previous history of a DVT. So if they have no known history of DVT, they said they've never had one, you have no medical records of them ever having one, the likelihood of this being a chronic DVT, it's pretty low.
Right. Okay.
So I'm just. Especially if it's just like, one little segment, that's the only spot you see. It's like, and it's also, it's because similar on both sides of the vessel too, so it's like similar to that side as well as that side. So what could potentially look like that would be our valves. It's almost like a mirror image, So first things first, acute or chronic?
Chronic.
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 Stop. Are you going to say acute? Why is it filling?
Why is it filling? Because it's partially occlusive. That look like chronic DVT. Does it look like a thin linear echogenic?
I don't know, Dan. I can't remember all them. I
It's a
can just
big
remember,
honking
like,
clot.
one thing at a time.
Well, it had like flow in it. That's why I thought.
Yeah,
It has
see,
flow, yeah.
me and you, Miriam. Amazing vascular text.
Right.
That's why we're doing this course.
Okay. I mean, I could tell it was like a giant clot.
Yeah, so giant clots are gonna be acute. Chronic are gonna be these thin linear echogenic, like irregular things. So you're gonna have almost a complete recanalized vessel. So it's gonna be almost nothing chronic DVT. So there's no way you can call that chronic.
Okay.
So yeah, so that's acute DVT, which is partially occlusive. So this is a partially occlusive acute thrombus. What is it saying? In the right popliteal vein. So that's another thing I've got to mention. This person augmented. As soon as you see a thrombus, stop augmenting. There's no need to augment. There's already thrombus there. And you also potentially run the risk of potentially embolizing that thrombus. So like if I had to submit this image for like my vascular lab accreditation, we'd fail. They don't want to see you augmenting when there's presence of thrombus. So this is like a horrible image to take a picture of. So you do not want to augment when you see a thrombus. In addition, if you encounter a DVT and you're in the outpatient setting, don't let that patient go. Especially if it's an acute DVT, they have to most likely wind up in the hospital. And DVT is considered a critical emergency. So you have to contact a physician and you have to contact the doctor. So oftentimes in the hospital, you're going to be reaching out to the PA taking care of that patient and just giving a preliminary report like, hey, I just did the low extremity Doppler on Mr. So-and-so. Just wanted to give you a preliminary report. They're positive for acute DVT and right common femoral, left leg, and then you document who you spoke to. It has to be a doctor, a PA, or a nurse practitioner. Someone that's able to prescribe medications and it's overseeing the patient. So you can't give a preliminary report to just the nurse and the RN. And then if you're in the outpatient setting, you have to call that ordering physician who ordered that exam, let him know, your patient it's positive for DVT. What do you want us to do? Do you want us to call the ambulance? How do you want to proceed? Because if it's just maybe a small caffeine DVT, that person's physician may elect to just treat them with medications on an outpatient basis as opposed to having them hospitalized. So At least then it's out of your hands. You've notified the doctors, you know, you've done your part. So anyway, so I digressed. So anyway, so this is an example of a partially occlusive DVT. So since it's partially occlusive, we were still able to get an augmentation, which we know we shouldn't do. And we're above the level of the thrombus. So we are getting some phasic respiratory variations. So if this clot was more proximal, we could potentially have decreased or reduced phasicity or respiratory variation. Oh, I don't know, what did I do? Right. So this is a good example too of another partially occlusive DVT. So again, I would call this acute, you know, it's hypoechoic, anechoic. So this one might be, if I saw it in real time, might be flapping around, free moving. So this is important why you need to get a nice color Doppler picture showing full vessel filling. So you may not necessarily pick this up. So this is a small DVT that's adhered to the wall. Potentially this could have been larger. Maybe some of it embolized and broke off already. So this is all that we're seeing. But again, this would be, you know, I would describe this as acute DVT seen within the right common femoral vein, which is partially occlusive and demonstrates partial compressibility. So this is good. So this person did not augment. So that's the right thing you should do. You guys can all see this, right? I think I lost you.
Yes.
Yeah, okay. Stop share. What does this look like? So we're in a transverse view.
Okay, it's thin and echogenic, so I'm saying chronic.
Acute.
Now you guys
hate that. I hate
covering
this.
all your bases
So
here.
one of us is right, you know.
So this is actually what an IV catheter will look like within a vessel in transverse. So this is probably a vessel in the upper extremity. I'd say maybe brachial vein. So this is an IV catheter within the vessel. Again, so if you have any questions, you turn in long. So you see something like this, when you turn in long, probably going to look like this. So that segment of that IV catheter will look like this when you turn it along. So you can see the tube of the catheter. That's going to be your IV catheter. Like you'll know the patient has a central line or a PICC line. And that's what the tube of the catheter is going to look like. So this is a central line or a PICC line. So this runs from, typically they go into the basilic vein in the upper arm and they'll run it through the axillary subclavian into the right side of the heart to deliver medications. So if you look at this picture, you see the catheter. So again, these catheters are nice surfaces for clots to form on. So if we go a little further down over here, we see thrombus along that catheter line. There's partial flow getting through. So this is acute thrombus, which is partially occlusive, seen along the PIC line within the right subclavian. If I had to describe that, I'd say acute thrombus noted within right subclavian vein, which is partially occlusive. So we don't compress the subclavian vein, so I can't mention about compressibility, but I'd say, acute thrombus seen in right subclavian vein, which is partially occlusive along the PIC line, along the visualized segment of PIC line, something along those lines. So I was trying to find some examples of worksheets that you might encounter. In my lab, it was like instead of competent, it would say like compressibility. So I'd have like each segment is a compressible. SFE was typically broken down into proximate distal. We also had a trunk section that we'd have to fill out. So we'd have to, is it compressible? Was there augmentation? Describe if the flow was spontaneous, if it was phasic, pulsatile. This was an example of like a preliminary write-up that you might have to do. This patient came in with right lower extremity edema, so indication's good. Preliminary report, say the common femoral vein, popliteal, peroneals, posterior tibial veins were all assessed for patency. B-mode ultrasound demonstrates a non-compressible and dilated popliteal vein with hypoechoic intraluminal debris or intraluminal echoes extending just above the knee, partially obstructing the popliteal vein or demonstrating partial flow on color Dopplers and spectral waveforms. So again, so they're describing that it's a partial flow. They're describing the intraluminal echoes. They're describing the compressibility. It was non-compressible. So all other vessels are compressible. So I like my favorite line is like all vessels of right lower extremity are patent and compressible, demonstrating normal phasicity and normal augmentation. So under their impression, this is when you would write like your preliminary findings. So evidence of acute DVT in the right popliteal vein. Oh, and the other thing too is incidental findings. So don't be afraid to document and note incidental findings on your venous duplex reports. So you may be going in there looking for a DVT, but you may encounter other things while you're scanning. And a good sonographer isn't going to just ignore those. I know there are those out there that potentially would, that's more work for me. I got to take more pictures. But a good tech isn't going to ignore these things. So potential. Incidental. what are some? What do you think? What could be a potential incidental finding? If we're doing legs, say we're doing legs.
Baker's cyst.
Baker's is good. Yes, this could be our number one. So yes. So we encounter a Baker's cyst. We're gonna measure. Long. Trans. You take your measurements in long and trans. Get your 3 dimensions. Anything we come across in ultrasound, we're always going to put color on it. Color Doppler. We want to demonstrate that there's no flow, that it's not like a big bleeding hematoma or something like that, or pseudoaneurysm, God forbid. So we're going to put color flow, color Doppler on it. Make sure there's no flow to a Baker's cyst. Something else, what's another potential incidental finding? What could we document in the legs? Anyone? What about lymph nodes?
That's what I was gonna say, what we just saw, lymph node.
Lymph nodes, yeah. So lymph nodes, yeah. So particularly, they're going to be our inguinal lymph nodes. Those are the ones in the groin. Those are the largest ones and the ones that we typically see. So enlarged inguinal lymph nodes. So we're going to document them, lymph nodes. So document if enlarged or atypical in appearance. So again, we're gonna measure long trans. Color Doppler on it. It becomes second nature for you, just putting color on everything. Oh, I lost Miriam for a second. Lymph nodes. So we're going to document if lymph nodes appear enlarged or atypical in appearance. So the reason being, if they're atypical in appearance, this patient could potentially have lymphoma and not even know about it. And you might be the first person to discover these atypical lymph nodes and, set this patient down the path, to get treatment for something like lymphoma or cancer. So if a lymph node looks funky, looks weird, don't ignore it, take pictures of it, even if it's not necessarily that large. Patients
Is
yeah.
enlarged greater than a centimeter or?
Yeah, so so my radiologist said greater than a centimeter in AP, so the short axis. Doesn't hurt to take pictures, if you want to add if you see a lymph node, document it, take a picture of it, Lymph nodes will commonly be seen, seen patients. Or wounds. So patients with a cellulitis infection in the leg, we get that order a lot for roulotte DVT. You'll more often than not see enlarged lymph nodes. So if I start my exam, I'm at the common femoral, I see a bunch of enlarged, hypervascular, angry looking lymph nodes. I know this patient probably has a raging infection in this leg. If the leg's beet red, I'm like, this is most likely going to be cellulitis, So the doctor will also use some of that, information to kind of support the diagnosis for cellulitis as well. Also, if a patient has a wound in the leg and they're healing, they could potentially be an infection. So that's going to cause enlarged lymph nodes. Anyone think of anything else? Potential incidental findings? We're doing a DVT study, a low extremity duplex.
Would you document like varicosities or?
Sure, yeah, we can do that. So I would document varicosities if they were very large and if they're thrombosed. So if they're thrombosed and they're small, definitely document thrombosed varicosities. So varicosities. Large. And thrombosed. So another potential incidental finding, could be hematoma. Mass or lesion. So a patient could have like a myeloma or mass or lesion within the muscle or tissue. Hematoma. Potential joint effusion. One of my favorite incidental findings that Dr. Pellerito always taught us to look for is occluded arteries. So their arteries and veins, they're friends, they're buddies, they run side by side, they go together. So a good sonographer will also be looking for occluded arteries while he's doing a DVT study, because they're coming in for pain. Maybe that pain isn't a venous symptom, maybe that pain's an arterial symptom. So I won't go crazy documenting stenotic arteries if they're really calcified, but if I see an artery that's completely occluded, I'm going to document that. That's going to be another incidental finding. So that's why in his lab, he likes to do color Doppler in transverse, or put your color box on in transverse while you're doing your compressions. And he wants to see a picture of that artery showing flow when you're doing your compression. So you compress your vein, vein's gone, you still have your color box on there. He wants a picture of that artery red. So we can say, yes, there's arterial blood flow in this segment. That's what he asked of us and required of us. Any questions about any of this? You guys feel like sonographers yet? Kind of.
No.
No. It's all right. Got 2 more semesters.
I don't know if that's enough.
How's physics coming? You guys studying?
I'm still like going through. I have like a bunch of note cards. I haven't like continued on like past what I've already been studying, but
Okay.
I will probably try to work on that at some point.
Yeah.
I still need to get those artifacts down. I think that's like the last thing I need.